next we invite Dr. Harika Premavada to present on factors predictive of recurrence in MOG positive optic nerve.
Good afternoon, respected judges and one and all. I'm Dr. Priyamvada here to present my paper on factors predictive of recurrence in myelin oligodendrocyte glycoprotein MOG positive optic neuritis. We have no financial disclosures. MOG is a IgG1 antibody-mediated autoimmune demyelinating disease with the spectrum of optic neuritis, encephalitis, and myelitis, where optic neuritis is the most common presentation. It is a distinct entity from multiple sclerosis optic neuritis and NMO optic neuritis, and the incidence of MOG optic neuritis is more than multiple sclerosis optic neuritis in Asian countries, especially India. Acute unilateral or bilateral optic neuritis with papillitis, long segment involvement of optic nerve, being steroid responsive, having recurrent episodes are the hallmark findings of MOG optic neuritis. Recurrences may occur in about 1/3 of cases. However, there is limited prior literature on these aspects. Hence, we aimed at identifying the factors predictive of recurrences in MOG patients. Ours is a retrospective observational study comparing the recurrent and non-recurrent cases done at a tertiary eye care center LVPI in India between 2019 and 2023. Though some of our patients have clinically MOG positive, but we only included those who are serologically positive for MOG antibody and negative for NMO, and we preferred cell-based assay because it is gold standard. We included patients of all age groups with a minimum follow-up of 3 months, considering 3 months is required to document a recurrence. Electronic medical records of 72 patients were reviewed, and the data was collected for age, gender, clinical features, best corrected visual acuity, optic disc findings, constitutional symptoms like pain, fever, and neurological symptoms like ataxia, headache, seizures, and limb weakness. MRI or brain and orbits were studied for the involvement of the segment of optic nerve. HVF mean deviation and pattern, OCT, RNFL thickness, and MGCL thickness were compared. Treatment is given with IV MP methylprednisolone, and the days of treatment is compared. Immunosuppression is with azathioprine, rituximab, and MMF is given, and those data are compared. Visual outcomes and number of recurrences were also documented. A total of 48 patients met the study criteria and were divided into 2 groups, recurrent and non-recurrent. We did a statistical analysis using Stata software, and p-values less than 0.05 were considered significant. These are our results. 27 and 21 patients respectively were included in the recurrent and non-recurrent groups. Though our patients age range from 1.5 years to 61 years, the median age in the recurrent group is 37 years and 23 in the non-recurrent group. Yes, our patients are slightly older in the recurrent group, but there was no statistical significant difference between the groups. There was no gender predilection. Constitutional symptoms, neurological symptoms, papillitis, long segment involvement, posterior optic nerve involvement are all respecting the previous data, but there was no statistical difference between the groups. The statistically significant differences we found are unilateral presentation is more in recurrent group, pain on eye movements was more in recurrent group, and immunosuppression when not started had more number of recurrent cases. So these are the depiction. 59.3% patients had pain in the recurrence group, whereas only 33% patients had pain in the non-recurrence group. So the proportion of pain was statistically significant higher in the recurrence group as compared to the non-recurrent group. Similarly, the laterality, there was statistically significant difference in the laterality since the majority in the recurrence group had OS as a presenting eye, that means the unilateral presentation, whereas majority in the non-recurrence group are bilateral presentations. We also found that immunosuppression at first visit when started showed less number of recurrent cases, and these were the data depicted in the table and pie charts. Most of our patients had long segment optic nerve involvement, and the following charts depict the distribution of the data. Best corrected visual acuity at the present and the final follow-up acuity are not didn't show any significant difference in the groups, but the p-value within the groups, that means the logmar value of 2 has improved to 0. That means they are improved very well with the treatment IV methylprednisolone and the immunosuppression, and the prognosis is good in both the groups, and it is very much statistically significant. Similar findings were seen with the mean deviation on HVF, so that also indicates that there is a good prognosis and which is statistically significant within the groups. The distribution of other data are depicted in the following slides. More patients had papillitis presentation, long segment involvement. Similar studies studies similar to our data showed young adults and standard first-line immunosuppression or prednisolone were associated with decrease in risk of relapse, which is similar to our results. The major strength of study is that it is one of the largest studies of MOG antibody disease and one of the first studies comparing the recurrent and non-recurrent cases. Limitations being its small sample size, especially in respect to the statistical analysis. So we conclude that pain on eye movements and unilateral involvement were the factors associated with increased risk of recurrence in MOG optic neuritis. Treatment with immunosuppressive agents at first episode of optic neuritis have shown less rates of recurrence. Understanding the long-term relapse risk may help clinicians to decide on when to start the immunosuppression treatment. However, larger further prospective randomized control trials are needed to validate these observations. These are my references. Thank you.
Well done study. What is the most important predictive factor you have found? Pain is the only one?
So depending on the statistical analysis, unilateral presentation was more significant, sir. And we also found that having presence of pain on eye movements while presentation is also statistically significant. And also starting immunosuppression at the first episode was also statistically significant, sir.
So those associations are by univariate analysis. Did you do a multivariate analysis? Because there may be many other factors, because you have chosen as MOG plus or minus.
Yes, sir.
So how many cases did you exclude from the sample size? Because you have a small sample.
So we actually almost screened 700 plus patients, and those who are MOG positive are 72. But we took at least 3 months follow-up is needed. That's why we had a small sample size. Multivariate analysis we can do, sir, but univariate analysis is better because the sample size should be at least 30 in both the groups to compare with the multivariate analysis. But the univariate analysis, it definitely proven all these statistically significant values, sir.
Okay.
That's why multivariate was, the results were calculated, but we did not present because the sample size is not 30 at least in each.
Okay.
Yes, sir.
Good. Thank you.
Thank you, sir.